This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm TG LaFredo, and this week on the program, I'm coming to you from KRMC Home Health. My guests are Candy Huerta, RN. She's the director of KRMC Hospice and KRMC Home Health. And Yvonne Barger. She's the manager of KRMC Home Health. Ladies, welcome.
Thank you.
Thank you.
KRMC provides services to patients in so many different ways. What is home health? Let's begin there.
Well, home health is a model of medical professionals that will come out into the home and provide services to help patients kind of get back on their feet and get back into the community, hopefully is our goal. So the services and things that we'll provide are skilled services, meaning that it takes a skilled nurse, a skilled therapist to provide these services. So many of these services are if there's a new disease, if there's maybe somebody was ill in the hospital and now they're coming home with maybe IV antibiotics. So we'll help the patient or their family provide these antibiotics, help them do that in their home environment instead of the hospital. If they come home with, say, a new ostomy, a Foley catheter, things like that. So we will teach patients and their families how to manage these in the home. Some of these are lifelong changes that they'll have to deal with. Some of these are temporary. So we'll guide them and help them through that process.
Home health is directed specifically at people who have less mobility. Is that the idea, that they have a hard time traveling for appointments?
So to be on home health, Medicare requires that these patients they have difficulty getting out of their homes, so they have to be what we call homebound. That's different than bedbound, but they're homebound, meaning it takes a difficult time to get out. They need assistance to get out because of maybe what's happened to them, a surgery, a fall, maybe they just had a fractured hip. We will go in and help them there in the home so that they can hopefully eventually not be homebound.
When I hear about home health, I tend to think that your patients are primarily older folks. However, when you mention surgeries and some of those things that come up unexpectedly in life, then I have to kind of rethink. Do you also have a fair amount of younger folks who
Absolutely, yeah.
Yeah. We take care of all ages of the spectrum. We don't specialize in the pediatric just because we don't have the pediatric nurses on board for that, but we will take the older pediatric, so your teenage level, and up to 100 plus.
You touched on a few of the services you provide. It's actually quite a list. Can we talk about those in a little greater depth?
Sure. So skilled services are going to be things like your cardiac monitoring. Maybe they just had a cardiac event and now they're coming home. So there's new medications. They might have a life vest on. They may have a new defibrillator that we're dealing with. And so we're teaching them. So disease management, they may have just been diagnosed with maybe a new disease, such as congestive heart failure, maybe diabetes. So there's some education and things that need to go on that with the patient and the family so that they can manage better, hopefully at home. We will teach them how to do injections, and again, infusion therapy. We'll do some instrument care, such as your respiratory, the urinary ostomy, the feeding tubes, things like that, to hopefully keep them in the home environment versus the hospital. If they do have IV infusions, we'll manage the PICC line care too, which is the IV that is how that's going in. Medication management, a lot of times patients will come home on new medications that they're not familiar with. That can be overwhelming, and it can be dangerous if they don't know how to manage their medications. So medication reconciliation when they get home is a huge part of home care, home health. And then including the patient and the caregiver. Sometimes the patient is not able to manage things, but their caregiver can. So the caregiver is very important in the education process through all this. And then there's always that acute type things that occur. So maybe they fell and hurt their knee or had to have a hip surgery. So post-surgical and post-hospitalization care we do manage. And then we do wound care. We have a wound care specialist. Yvonne is certified wound care. And so she is super good about helping the staff and the nurses when we have complicated wounds, what do we need to do? She also helps guide some of the physicians through that because that's not always their specialty. So wound care is a huge part of home health.
Yvonne, could you give a little insight on wound care?
So we run into a lot of different patients. It could be something as common as a skin tear, or it could be complicated, a post-surgical wound that needs skilled nursing. We also work with wound vacs. It's a negative pressure wound therapy system that requires a nurse to apply that several times a week.
This is something you can do in the home.
Yes.
No kidding. So what does that look like? What is the technology like?
So a wound vac has a clear film that protects the skin, and then a foam goes into the wound that serves as the basis for granulation tissue growth, so that foam actually touches the wound bed. Then more film goes over the top, and a tube runs from the wound to a vacuum, and it turns on. The patient carries that around during the day. They're able to do things in the home, and then we come and change that dressing. The process of negative wound therapy is there to promote granulation tissue, so it actually pulls the wound edges together and makes the wound heal faster.
Wow. That's I know nothing about that.
It's an impressive technology.
Yeah. Yvonne, I know that, or what I've learned actually from hosting this program, is that diabetic patients have a high risk for foot ulcers. Is that something that can also be treated in the home generally?
Absolutely. And we have a lot of different wound care products that we utilize on diabetic patients, and we teach them about foot care for after the wound has been healed so that the wounds don't recur. We also teach them about offloading, proper footwear, going to a podiatrist. So there's a lot. In addition to the medication management and education that we do with the diabetics.
I know from speaking with so many nurses over the years that there are so many different avenues in nursing. If I may ask, how did you come to specialize in wound care?
I thought it was fascinating.
Yeah.
And so I worked with a wound care center in Bullhead City and got my credentialing, and I've been doing wound care ever since.
Is it still fascinating?
It is.
Yeah. So we're talking about home visits, and when a patient qualifies for Medicare or Medicaid and is receiving home visits, how many visits per week are we talking, or will it depend on the situation?
So it always depends on the situation. So different things will require different types of care. So a wound care, for instance, say it's a wound vac, that could be 2 to 3 times a week to manage that. If it's for education and just kind of trying to keep the patient out of the hospital because they've been a little unstable, that could be maybe 2 to 3 times a week. And then we will back it down a little bit until they're pretty stable and are managing well. So it just depends. If it's an infusion therapy, wound care, some of those initially will require more visits. So it just depends. And it also depends on their insurance. Sometimes the insurances will come in and their goal is to give us so many visits, and their expectation is that you do your education, your teaching, all the required skilled services, trying to get all that in so many visits and then discharge. So there's so many variables that go with that, but we try to provide as much as we can to every patient for their particular need.
Let's try to get a little bit of free medical advice from our 2 registered nurses. I know a lot of times when, for example, someone's recovering from a surgery and friends and family will pitch in and say, well, let's go check on him. Let's get him to his appointments. And I guess what I'm looking for is, what is the line for this? Okay, this is something we can manage at home, or this is something we should really look into home health to get a visit from a nurse. How do you make that determination?
So most of the time it's because somebody's had some change in condition, something changed significantly that maybe they're overwhelmed, maybe they just are struggling, maybe they keep ending up in the hospital for the same thing. And so the referral will come from either their physician or the hospital. We can go out and talk to them and kind of assess their need, meet them where they're at, right? What is going on? Why do you keep ending up in the hospital maybe? And then we can kind of go from there and do the education and provide the services that are needed. Maybe they keep falling. So what does that look like in the home? What is a barrier maybe that is in the home? So as a home health staff, we can go out and we can assess the home where the hospital staff doesn't have that ability to see really what's going on. It could be that we just need to make some corrections in the home. Maybe therapy can come in, make recommendations for more safe environment, grab bars, equipment that may be needed to keep them safer. Maybe their walker is set too short and maybe we need to reassess that, and our staff can come out and assess that. We have such a great team of different disciplines that can provide so many different services, and so we can kind of figure out what's going on and hopefully help correct some of the issues and the education and help them stay at the home instead of having to go into a hospital.
If you're just joining us, this is Focus on Your Health. I'm TG LaFredo, and this week on the program, I'm visiting with KRMC Home Health. My guests are Candy Huerta, RN. She is the director of KRMC Hospice and of KRMC Home Health. And Yvonne Barger, she is an RN, and she's the manager of KRMC Home Health. Mojave County is a huge piece of land. If I'm not mistaken, I feel like I read that it's in the contiguous United States, it's the 5th largest county. So it's huge. What is the size of your service area for KRMC Home Health?
So there's quite a few communities in Mojave County that do have a lot of the same type of services, so your home health and your hospices. So in our particular area, we tend to stay in the Kingman area. We do service Chloride, Dolan Springs, Meadview, the Kingman proper area, Valley Vista, and we will go out on I-40 to a certain point, and then anything beyond that is case by case. We don't go into Lake Havasu. We don't go into Bullhead. Those areas tend to already have enough services, so we tend to try to provide the services where the service is needed. And so the Kingman proper is the majority of it, but we do have quite a bit of area going down 93 and in that direction.
And Meadview is pretty rural. So I guess the message is if you're living in a rather far-flung area, you can always ask the question and see.
Yeah, and see. And sometimes it's case by case. We do have a nurse that lives in that area, so we're blessed with that. So she can provide the services there without having to do as much driving.
Now, you touched on the size, or this kind of the size of the team or the scope of the different specialties. Mm-hmm. If I may ask, how many employees do you have with KRMC?
We have about 30 employees in home health.
Let's talk about some of their different specialties.
So we currently have RNs and LPNs. We have LNAs, which is like a CNA, but they're more licensed, so they can do a little more than a CNA. We have physical therapy, occupational therapy, and then we have assistants for both of those. We have social workers, and then being connected to a hospice team, we have the ability to cross over some of our staff, meaning if somebody's having bereavement needs or if we need to bring a chaplain in, we can do that for some of the needs that we find in the home or something. So we do have a great plethora of disciplines in our small little group, which has been a blessing to our team.
The reality of delivering medical care is oftentimes nurses and doctors sort of serve as de facto social workers. They look at the problem of the situation, what a patient or the patient's family is dealing with, and try to come up with solutions. Can you say a bit about what your nurses, or maybe in particular the social workers on your team, some of those services that they help to provide for patients?
Well, many times our nurses assist families in finding the resources that they need if they need extra food in the home. We've recently had nurses help with resources to turn power back on or to keep power on. Our social worker will come out and talk to the families about legal documents associated with their medical care, like how to prepare a living will and give them the paperwork to do that, or instructions on where to find that information, medical power of attorney as well.
Mm-hmm.
Let's talk a little bit about some of the physical services and occupational therapy involved in home health visits.
Okay. So we do have physical therapy and occupational therapy. So your physical therapist will go out into the home. They help the patients with strengthening. They're really good about educating not only the patient, but maybe their caregiver on helping with transfers and safely doing things in the home, making sure that their equipment and their pathways are safe. And then we also have our occupational therapist. So occupational therapy is kind of a discipline that a lot of people don't understand, right? They think it's just physical therapy, and it's not. So it's a different offset of that. They work kind of together sometimes with the patient. But what occupational therapy does is they help them with their everyday living activities. We've had our occupational therapists out there, making sure they can cook safely. So they literally are standing there with them and showing them tricks to the trade to make sure that they can cook and still maintain things in the home safely, and making sure they can get in and out of that shower safely, making sure that wheelchairs and things like that are safely.
Car transfers.
Yeah, car transfers. So it's really an interesting discipline. So they kind of do offset things that we don't think about. And then they bring that back to the team to help the rest of the disciplines focus on where those needs need to go. So it's a great mixture of different disciplines that have so many different expertise to their field, and then we can all, every week we get together and discuss what's needed more for this patient, or what do we do next? Are they graduating? Are they getting better? Or do we need to look at something different to help them get where they need to be?
You mentioned the connection that KRMC Home Health has, of course, with KRMC Hospice. And in some cases, a patient might have to transition to those services. How does that work?
So when you have a patient that, let's say maybe they have cancer and we've had them on service for a while, but they're kind of getting to the point where they no longer want treatment, you can see that they're getting tired and they need a different type of care. So now we're transitioning into that end of life care. The beauty of hospice is I can send once we've had the conversation with them, we get their permission. Are you okay with somebody coming out and talking about hospice? Then we can send a nurse from our hospice team out, and they can kind of educate and let them know what hospice is. What does this look like? And how would this benefit you and your family? And then kind of go from there.
Ladies, here in the tri-state area, there are several organizations that do provide home health services. What makes KRMC Home Health special?
Well, the beauty of KRMC Home Health is we are one of the oldest home health agencies in the area. So we've been here the longest. We are a 5-star patient satisfaction, and we were just awarded the top 5% of our patient satisfaction. And that goes with, a lot of these home health agencies, not only in the state, but in the nation. So that is a huge piece for us. We're also connected with KRMC, which gives us a lot more of the ability and the services that we can provide. We can transition from one piece to this piece to that piece in a continuity of type care. So we have that as well. But most of all, we have what I feel as the most amazing, compassionate team ever. I have been a nurse for 30 years, and working with home health type nurses and hospice nurses, extremely compassionate. They fall in love with their patients. They make sure that they have what they need. They go above and beyond, even above and beyond what we provide, they personally will provide. I mean, I've had them out there building ramps and things to help people get into their home safer, and they're doing this on their own. So they provide so many types of just the heart and the compassion. So above all, I think my team is amazing.
Let's talk a little bit about the referral process. How do patients come to KRMC Home Health?
So to be on home health, you do have to have a referral from a physician. Your primary care, if you had surgery, so the surgeon, we have to have a physician that will sign and certify them for home health. We're nurses that go out and take care of patients, so we have to follow the orders of the physician. So there's a plan of care that's put into place to be able to take care of our patients. And this is all managed and signed by the physician. But it can be a nurse practitioner or a PA now. So COVID did change that, which was a beauty of what came out of
for the better,
if we had to go through that, right?
Right.
Because before, Medicare would not allow those two disciplines to sign for home health. So now we have that available. So that opened it up more for patients that are seen by maybe a nurse practitioner or a PA.
We've talked a bit about Medicare and Medicaid and how that figures into home health and the equation. We always hate talking about money and talking about insurance on the program, but it is the reality of medical care. How do patients, or what are the avenues patients use to pay for home health services?
When they come on home health, generally we have already got the pre-approved services through their insurance. So we do all that behind the scenes prior to them actually being seen first. Most insurances will pay for home health services. If you're straight Medicare, it's 100% covered. All the other insurances, there's usually an authorization piece that goes with it. When we get out there, they will know exactly what the expectation of the insurance is versus what maybe their cost might be. So that's discussed with the patient prior to starting services so that they're comfortable with that as well. But generally, most insurances do have some kind of a benefit for home health. But like I said, we do try to find that out prior to so that the patient's aware and we're aware of what we're dealing with. We accept most insurances. There are still some that we don't or we do. It just depends on the situation.
Candy, not long ago, we also got together and talked about KRMC Hospice. And something that really strikes me about the conversation with hospice and with home health is just all the work that you and your team will do kind of behind the scenes, because these are patients who really, they have a lot going on. They need to be able to focus on resting and getting well and maybe rehabilitation and not paperwork and logistics and the pain in the butt that is that, right?
Correct.
And the way that your teams are able to facilitate that so well and
we
streamline.
try to make it as seamless as possible to come on to service. And again, it just depends on what type of insurance they have. You know, sometimes we have people that move into the area newly and they haven't moved their insurances over and things like that. So sometimes things get a little complicated with the insurances and stuff. Our goal is to try to eliminate as much cost from the patient to the insurance, right? These guys are already paying the insurance, so we want to try to make sure that the insurance is picking up what they're supposed to. So we try to inform the patient and the family of that prior to the services being rendered to make sure that they're comfortable with that. But yeah, we try to do as much of that as we can behind the scenes. You know, maybe another referral might be needed to go somewhere else, so we'll try to work with that with the team to see what else they need for their care. And then upon discharge, if they need certain supplies and things in the home, upon us leaving, then we will have that, try to get that set up so that that will start flowing in as we're leaving, so that there's kind of a smoother transition for that. And hopefully, I guess maybe hopefully meeting the goals of the beginning of the services. So we always set goals at the beginning of the service, hoping to meet these goals to get the patient back to their baseline or even further than that if we can, especially if they've had mobility issues. What was their baseline before maybe an event occurred, and can we get them back to that baseline or even better? And we've had some situations where we've been able to actually get them better and moving more independently. So we've had some pretty good success stories. It's fun to watch your patients improve and I want to say live healthy and happily ever after.
That is Candy Huerta, RN. She's the director of KRMC Hospice and KRMC Home Health. And Yvonne Barger, RN. She's the manager of KRMC Home Health. Ladies, thank you so much for your time today.
Thank you. It was our pleasure.
Thank you.
For more information on KRMC Home Health, you can call 928-757-0630. That's 757-0630. And that is the program that's focused on your health. I'm TG LaFredo. Thank you for listening. Stay healthy, and we'll catch you next time.